بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. أنا أحب أشكر الموجودين وبشكر الدكتور حسين على الدعوة، وإن شاء الله أنا بسرعة كده إن شاء الله أشوف الحالة دي بس. ده عيان 71 years old man with no significant medical history, presented with a few months history of dysphagia to both solids and fluids and weight loss. Physical examination of the patient and laboratory investigations were unremarkable. Upper endoscopy was done for the patient, which revealed a well-defined, most probably cystic lesion by indentation of the lateral wall of the distal third of the esophagus with normal overlying mucosa, causing significant narrowing of the esophageal lumen, suggesting submucosal lesion or compression from outside. So AOS was decided that was done, and it revealed a large submucosal and echoic cystic lesion without solid components inside, measuring 8 by 9 centimeter with a smooth cystic wall lining containing the fourth layer, suggesting intramural lesion. AOSF and AO of the cystic component was done, and whitish fluid with thick consistency was aspirated. Cytological examination of the aspirate was inconclusive, showing only scattered red blood cells and lymphocytes in an eosinophilic material, suggesting contents of a benign cystic lesion. Then PET-CT was done and revealed a low-activity cystic esophageal intramural lesion, supporting the diagnosis of a benign esophageal cyst. Incision was done using the needle knife. After deepening the incision, a whitish fluid was coming out from the cyst. Then a guide wire was passed through the incision to no extension was seen inside the cyst, revealing the extension as seen in this image. After passing the guide wire into the cyst and turned it around itself, the cyst was fenestrated through extending the initial incision by the needle knife distally for a distance of about 5 centimeters. When the incision was large enough, the endoscope was inserted into the cyst, and the remaining content of the cyst were suctioned completely. The cyst incision site were examined to confirm hemostasis. This is a view of the upper endoscopy inside the cyst. The procedure was done on outpatient basis. Symptoms resolved immediately after the procedure, and the post-procedure course was uneventful. Second look upper endoscopy and AOS is scheduled 3 months after the procedure. In the review of literature, esophageal duplication cyst, a rare congenital malformation of the posterior embryonic foregut. The second most common following small bowel duplication cyst is the esophageal cyst. Patients are usually asymptomatic but can develop symptoms such as dysphagia in this patient due to compression of the surrounding structures. A few case reports documented the usefulness of endoscopic fenestration of symptomatic esophageal cyst in patients refusing or unfit for surgery. Similar procedure techniques were used in all cases with advice to dissect the entire length of the cystic wall to prevent recurrence, and the clipping of the lateral margins of the open cyst to prevent perforation. احنا ما عملناش طبعا clipping في الحالة عندنا هنا، بس احنا شفنا الهيموستاسيس كانت الامور كويسة بعد البروسيدور. All cases were uneventful and lead to complete resolution of the symptoms except one case which complicated 6 weeks later with secondary infection and recurrence of the symptoms, needed another endoscopic intervention to drain the collection. And these are the case reports. Some of the case reports. This is an esophageal duplication test management by endoscopic fenestration. And this is one which was complicated by the secondary infection, as shows this image. Yes. Then second look and second intervention was done 6 weeks later. And this is the site of the healed by the verticulum, healed all the site of the duplication cyst. Another case report endoscopic fenestration of esophageal duplication cyst in a 32 years old female refusing the surgery by doing a hole here in the duplication cyst, and this is the site of the healed one, and this is the log of the endoscopic ultrasound of the duplication cyst. Another case, endoscopic resection. This is use an ASD. This is a technique use an ASD and spraying anhydrous alcohol to kill the epithelial cell layer to prevent recurrence. It's not used in endoscopic ultrasound. Endoscopic treatment of esophageal duplication cyst by fenestration also in this 34 years old female patient without complication or recurrence on follow-up after 2 to 3 months. Another case of endoscopic fenestration here in outpatient basis also. And there is a endoscopic fenestration by AUS guidance for esophageal duplication cyst, showing the steps and ending by seeing the guide wire inside the cyst and doing a clips at the roof at the edges of the site. These clips are important for preventing delayed bleeding, preventing perforation, and the leakage, because mediastinitis is a very major complication, and only preventing re-epithelialization of the cyst to form another cyst. Also, surgery is a standard treatment. Endoscopic fenestration is a feasible and effective procedure for patient refusing or unfit for major surgery, allowing for an outpatient procedure with decreased post-operative recovery time. And thank you.
لو بس نقطة أسترس عليها إن الأسوفاجيال دوبليكيشن سيست اللي في الميدياستاينم الفيرست تشويس سيرجريز اند سيرجريز اند سيرجري، لكن بالنسبة للستومك والديودينم ممكن تحط الفيرست لاين اوف تريتمنت هو الايه اللي انت عملته الرائع. يعني انت ده حالة يعني انا عملت 3 مارسبيلايزيشن اللي انت عملته ده، بس دي اروعهم حقيقة لان كبيرة جدا ومانجينج فيري ويل والعيان خف تماما. لكن اللي انا كنت انت قلت لي اعمل ايه وبتاع مش عارف ايه، انا قلت لك خلي الجراحة اول احتمال. ليه؟ لان كانت في الميدياستاين، فبنخاف جدا من الميدياستينايتس ونخاف جدا من البرفوريشن، انما الديودينم الاستومك كليبسين وخلصت الموضوع.